Thank you, Kamal sir, for giving me an opportunity to present on this platform. My talk would be a quick 5-minute run through the topic of localization of ventricular tachycardia, or PVCs, premature ventricular complexes. Ventricular tachycardia is characterized as a wide, complex tachyarrhythmia at a rate greater than 100 beats per minute. It is classified as by duration as non-sustained or sustained. Individually, each of these QRS complexes of a ventricular tachycardia are known as a PVC or a premature ventricular complex. In the successive slides, PVC will be used instead of VT. There are a lot of algorithms out there to help us predict the origin of PVCs, but male instincts took over and few guys completed the mammoth task of super simplifying the pathway for localization of PVCs. What they did is that they described a posterior view of the heart. In this description, the atria are cut out and the intercavitary structures of the ventricles are seen. They have divided the heart into four quadrants and broadly divided the PVCs into those with superior axis and those with an inferior axis. Inferiorly directed PVCs have positive reflections in leads 2, 3 AVF, while superiorly directed PVCs have negative reflections in the same leads. Few PVCs show inferior lead discordance, which have also been discussed. The PVCs originating in the upper quadrants record a positive reflection in the inferior leads. AVR and AVL, which are superior leads, also show a negative reflection because of the vectors directed away from them. The PVCs originating from the upper quadrant were further divided into a left-sided or right-sided originating PVCs. The right-sided PVCs have a positive reflection in lead 1, while the left-sided PVCs have a negative reflection. This gaudy picture best demonstrates the overlapping anatomy of the outflow tract. It's important to remember that all RV structures are not right-sided and all LV structures are not left-sided. As depicted by the mummy, the left arm represents the old LVOT, which starts on the left and is directed towards the right. The right arm represents the RVOT, which starts on the right, is anterior and directed to the left. This arrangement makes the pulmonary valve the most anterior and superior structure. The non-coronary cusp is the most inferior structure, while the right coronary cusp is the posterior most structure. Excuse me. In the left upper quadrant, picture the outflow tract and mitral valve in an anterior-posterior fashion and correlate the arrhythmia origin with the characteristic ECG morphology in lead V1. Since lead V1 is an anterior lead, the anterior-most structure like the anterior RVOT results in a typical left bundle branch block morphology. More posteriorly, like the region of left coronary cusp or iotomitral continuity origin is characterized on the ECG with a distinct R wave in lead V1. Finally, even more posterior and leftward, like the posterior mitral annulus, will have a clear right bundle branch block morphology. The PVCs from LV summit are a topic on their own. They have a broader QRS morphology suggesting an epicardial origin, a V2 break, a V2 pattern break, and they can also manifest as LBB or RBB morphology. In the right upper quadrant, these four structures show an inferior axis and a positive lead 1. Another lead, the AVL, which is a superior and a leftward lead, will show a QS pattern for PVCs from the outflow tract, while the PVCs from the parahischian and tricuspid valve annulus will show an isoelectric or positive deflection in lead AVL. This is because of the more inferior location of the parahischian and the tricuspid valve annulus compared to the outflow tract. Also, the forces from the superior tricuspid valve and the parahischian area are less pronounced than the more superior structures. Differentiation of PVCs originating from posterior RVOT and RCC is challenging. Transition at V2 or earlier suggests an RCC origin. Transition after V3 suggests an RVOT origin. If the transition occurs at V3, then the PVCs and the sinus rhythm transition is compared. If the transition of the PVC occurs later than the sinus rhythm, then the origin of that PVC is from RVOT. If the PVC transition occurs at or earlier than the sinus rhythm transition, then the so-called V2 transition is measured. The ratio of more than 0.6 predicts an LVOT origin. PVCs originating from the inferior aspect of the heart have a negative reflections in the inferior leads, and the bundle branch pattern helps us to tell whether its origin is from RV structure or an LV structure. PVCs with LVB morphology and superior axis may arise from RV structures like the inferior tricuspid valve annulus, the moderator band, or the cardiac crux. Left bundle branch block morphology PVCs may also be seen arising from the interventricular septum. PVCs with RVB morphology and a superior axis arise from LV structures, while the inferior mitral valve annulus, the left anterior fascicle, or the posterior papillary muscle. Once the quadrants are localized, the precordial transition of these PVCs suggests the likely origin. In case of PVCs with RBB morphology, the transition from positive to negative occurs early as we move from apex towards the base. In PVCs with LBB morphology, the transition from negative to a positive occurs early as we move away from the free wall towards the septum. The left quadrant structures are the inferior mitral valve annulus, the posterior papillary muscle, and the left posterior fascicle. Idiopathic PVCs can be differentiated arising from these structures on the basis of precordial lead transitions, QRS morphology, and lead V1. An RS ratio greater than 1 in V6 suggests a more basal location, which is seen in PVCs arising from the mitral valve annulus. An RS ratio less than 1 by V5 usually suggests a posterior papillary muscle or a left anterior fascicle origin of PVCs. RSR pattern and a QRS duration of less than 130 milliseconds suggests early recruitment of the His Purkinje system seen in PVCs from LPF. Cardiac crux is an epicardial space where all four chambers of the heart are in closest proximity. It's also the junction of the MCV and the CS. PVCs from this area have a left superior axis, an early V2 transition, and features suggesting of its epicardial origin, pseudo delta or the maximal deflection index of more than 0.55. The moderator band is a free-running muscular structure extending from the anterior septum to the anterior papillary muscle of the right ventricle free wall. PVCs originating here have a left superior axis and a later than V4 transition. Tricuspid valve PVCs have variable precordial transition from V2 to V4 anywhere between these leads depending on their septal or lateral aspect of origin. The inferior lead discordance are seen in mid-cavitary structures. Two kinds of inferior lead discordance are noted: positive negative discordance, which is a positive deflection in lead 2, and negative in lead 3. Negative positive discordance is negative in lead 2 and positive in lead 3. And the positive negative discordance are seen in RV structures and interventricular septum, while negative positive discordance are seen in LV structures. The maximal deflection index is interval between the earliest ventricular activation and the maximum deflection in each precordial lead. Taking the shortest interval is divided by the QRS duration. An MDA of greater or equal to 55 milliseconds had a high sensitivity and specificity to identify an epicardial ventricular tachycardia origin in patients without structural heart disease. In summary, with the diagram kept in mind in the background, this paper easily helps to approximate a localization of a PVC origin in a structurally normal heart. The same idea can be applied to a diseased heart, but it will be approximating the exit site of the PVC. All RV structures are not right-sided and all LV structures are not left-sided. Broadly, PVCs can be divided into those with superior and those with inferior axis. Lead 1 further divides the inferiorly directed PVCs into right or left-sided origin. The bundle branch morphology and the precordial transition is useful for the superiorly directed PVCs. Inferior lead discordance and epicardial origin are additional things to remember. Thank you.